Okay, guys, we're going to go over late adulthood today. So, our objectives today are to understand the biological and physiological changes in late adulthood, understand terminology associated with late adulthood, and have a basic understanding of OT's role in late adulthood. So, what is late adulthood? So, generally, we're considering the ages of 65 and older. So, we have what's referred to as young old, which is around the ages of 66 to 80, and then old, which is 80 plus. Typically, during this time frame, they often suffer notable deficits in physical, mental, or social deficits, often dependent or at risk for injury or illness, and often unable to live alone safely. We'll talk later about that more. Then we have some terminology we're going to talk about. So we have gerontologist, which is a scientist who studies biological, psychological, sociological aspects of aging. Then we have what's referred to as geriatrics, which is the branch of medicine that studies the diseases of the elderly. So when you go work at a skilled nursing facility, you're typically defined as you're working in geriatrics. Excuse me. Then we have what's referred to as elder speak, which is a condescending way people talk to the elderly as if they are children, using short sentences, exaggerated emphasis, slower speech, frequent repetition, using the word honey or dear instead of their name. Don't do this. This is not a good thing as an OTP to be doing. This can also happen reversely, where the patient is calling the OTP sweetheart, etc., having those hard and stark boundaries where you need to set, especially if you're not comfortable with being called that. So, some quick facts. The median age is rising in the United States population. The median age is around 38.1. Baby boomers make up just over 20% of that population. So remember, baby boomers are those born between 1946 and 1964. Approximately 41% of ages 65 to 79 adults have at least one disability. Typically, these disabilities will include issues with self-care skills, so ADLs, household, IADLs, as well as mobility in general. 71% age 80 and older have at least one disability around 50% of those have severe disability and 35% of those at least require some sort of assistance. There is a high correlation between increase in age and a decrease in physical activity and an increase in disability. Then we have physiological changes. So we have programmed aging theories, which is life expectancy is predetermined as cells are only able to divide a certain number of times. So as we age, the cell replication process will slow down. It's referred to as the Hayflick limit, which is the number of times our DNA and cells can actually replicate in our lifespan. Then we have random errors theories, which are random events occur over time. So the idea of wear and tear, I'm sure you've heard of that. Um, is where cells wear out from repeatedly being utilized, slowly killing themselves. Then we have free radicals, which cause damage to large molecule parts of the cells, and then the damage eventually stops organs from working. Then we also have mutations. So these can be chromosomal changes occurring randomly over time, genetically as randomly over time, changing genetic sequences and reducing cell viability. These theories state that functional loss is inevitable, essentially. I know it's depressing. Then we have successful aging models, which focus on adaptation and emotional well-being. So it's focusing on the importance of leisure skills. So about the quality of life, not necessarily the absence of disease. So leisure skills are those successfully aging participate in about 1.5 more leisure activities than those that don't. We should be focusing on supporting adaptation to aging and emotional well-being of our physical clients. Remember, functional loss is not necessarily inevitable. So an example of this, my great great grandmother was independent until she was age 100. Granted, she had some family that lived like very close by, so if she needed something, she could call them. But for the most part, she was pretty independent. Then my great grandmother was independent until she was in her upper 90s. She had a driver's license, kind of drove to church and whatever she needed to do. And then my current grandmother who's 88, almost 89. She's still driving occasionally, grocery shopping for herself. She is living with my family, but she's independently living in the basement that they converted to like a two-bedroom apartment for her. Hopefully, I can live as long as those. Then we have cardiopulmonary changes, which increase capacity used for daily tasks such as walking and dressing. So these people are going to get lethargic very frequently for what we refer as menial tasks, but them getting out of bed and getting dressed in the morning could be an all day wipeout affair. Then you have the SA node that may lose cells, which will then cause a slower heart rate, decrease in a mitochondria and total hemoglobin count. So with the mitochondria and hemoglobin, it's a decrease in muscle energy and efficiency of its utilization, which will then draw us to that first point of why it's increasing capacity that's used for daily tasks such as walking and dressing. Increase in vascular rigidity, including the aorta, so an increased risk of hypertension, which increases blood pressure, increases in ventricular hypertrophy or hypertrophy and stretching. Decrease in the alveoli function and mobility of the bony thorax. This can decrease in ventilation, overall lung capacity. Then you have your baroreceptors, which are less sensitive and may result in orthostatic hypotension. You guys will cover this a little bit more in detail next semesters. Um, orthostatic hypotension is a sudden decrease in blood pressure with body position changes. So these are your individuals that move from laying down to sitting up in bed, and they complain of being dizzy, lightheaded, weak, etc. Then we have body composition changes. So decrease in lean body tissue and an increase in body fat. Then you have a decrease in the body's ability to hold water, which affects the hyaline cartilage. The hyaline cartilage decreases in the body water affects composition of the cartilage. It's those intervertebral discs within the spinal cord. So you know the phrase older people basically shrink as you get older. That is due to the intervertebral discs of that hyaline cartilage that causes the person to shrink. This increases the risk of dehydration as well, which can damage discs and cartilage when exercising. Then you have the skin is thins and becomes more and more dry. So the skin thinning, why is that concerning? Um, so we need to make sure that skin integrity is and key. So we need to do constant skin checks regardless of the disability, diagnosis, etc. We should be doing skin checks with older adults. We should be telling them to do regularize their moisturizing routine as part of their ADLs, etc. Then we have neuromuscular changes. So this is a decrease in motor neurons. So neighboring motor units may sprout nerves to re-innervate. So remember, those motor neurons are some muscle fibers that are left without innervation. As far as the neighboring motor units, this increases the motor unit size. So functionally, it decreases the functional strength and impairs balance. It decreases speed of movement and the changes in posture. So there's a decrease in muscle mass. So you lose about 30% muscle strength between the ages of 50 and 70 years of age. You decrease in nerve conduction velocity, which there's less of a muscular response, which decreases your reaction time. It also decreases the ability to manipulate smaller objects, and think about the decreased flow as well. Some more musculoskeletal changes. So decrease in bone mineral content. So I know we talked to in middle adulthood about osteopenia and osteoporosis. So this increases fractures if we fall or if an individual falls. We have a decrease in mobility of connective tissue. The wear and tear in joints is referred to as osteoarthritis. Then we also have postural changes. So kyphosis and lordosis. So kyphosis is that upper back curvature referred to as humpback. And lordosis is that curve towards the front of the body, typically found in the lower back and the neck area. You have that decreased intervertebral disc height, which we referred to last slide with the hyaline cartilage. Sarcopenia will continue. So that's atrophy of the fast twitch type muscle fibers. And then falls can actually be deadly in this. So the mortality rate within 30 days of a fall is about 9%. If fall with an acute medical problem, that increases to 17%. With pneumonia, that rate then goes up to 43%. Over 25% risk of death within 1 year of a fall with a fracture. Some kind of crazy statistics for you. Then we have sensory changes. So all senses decline each year. So visual changes, so we have presbyopia, which is that idea of farsightedness. Increased difficulty with glare and low contrast, especially at nighttime. So these are why individuals that are older adults, find it difficult to drive at night. Some common diagnoses are cataracts, macular degeneration, glaucoma, etc. Dynamic visual acuity declines, so this affects IADLs, so namely driving, as mentioned with the driving at night. You have a decreased peripheral vision. You lose about 20 to 30 degrees of your peripheral vision in your 80s. It's going to be harder to distinguish colors due to those cataracts. And then how can we alleviate these and change these? So we can encourage brighter task lights, increase more contrast with what they're reading and looking at, bifocals, as well as some service animals too. Then we have auditory changes. So 25% ages 65 to 74 experience hearing loss of some type. 50% age 75 and older also experience hearing loss. We have what's referred to as presbycusis, which is the inner ear, age-related decline in acuity. Backing back up with hearing loss, up to 70% of individuals could benefit from hearing aids but don't use one, which is a crazy statistic. I'll tell you more about that later. Effects of function, think of socialization. Are they able to socialize appropriately? Are they able to pick up on cues? Are they able to understand what the individual is speaking and telling to? Think about mental health too. If they feel like they can't hear you or can't understand what you're saying, imagine how that's going to feel for that individual. So how can we alleviate these changes? Think about hearing aids, but aesthetics are more important. So think about what we can suggest as far as hearing aids and what is more sleek versus not sleek. How can we encourage them to read more or read lips, etc.? So backing up, story about this is my grandmother, who's 88, almost 89, that lives with my parents. She really truly learned how to lip read, as well as say uh-huh or act like she hears. She does a really good job of acting and pretending that she hears. Her sister is 82. She has hearing aids, loves them to death. She's trying to encourage my grandmother to get hearing aids. Unfortunately, hasn't gotten them yet. So funny story is my mom and my grandmother went to go get their hair did. Grandma was getting her hair done. Recently, my mom has lost a lot of weight with diet, exercise, all that good stuff. And the hairdresser had mentioned something about my mom losing all this weight, how she looks so good, all this, that, and the other. And the hairdresser had asked my grandma, "Oh, did she take that weight management drug or whatever?" And my grandmother, not knowing what she was saying and signing up for, was just like, "Uh-huh, yeah, 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 yeah." And it just it killed my mom. My mom was so angry. Oh my gosh, you guys should have seen it. It was during Thanksgiving break. It was insane. But just goes to show with the auditory changes, really encouraging your grandparents or your patients to really get hearing aids or some sort of hearing device. I know more new AirPods have that hearing device in them to just make it look like they're jamming out to something, but they're actually trying to listen to you, etc. Then we have vestibular changes, so that loss of the inner ear cells around age 55, it speeds up with further aging. So remember, our vestibular system is going to require our eyes, muscles in the joints, as well as our inner ear. So it's not necessarily one thing's being affected, it's all of these things being affected. You have this vocabulary word as far as presbystasis, which is a disequilibrium with no other known cause than aging. So that's where we kind of bring up they may present with a wide gait, so their legs are spread out more, they're staggering, they may make unsteady turns. It's an idea of fear of falling, so it's associated with poor health status and functional decline. So these individuals are are terrified of falling, whether they've fallen before or they're just scared of what could happen to them. Then you have olfactory and gustatory changes. So overall decrease in age. So how can we alleviate these changes? We can check pilot lights on the stove, water heater often. We focus on food appearance and texture to determine if it's safe or rotten. Looking at expiration dates, etc. It's an emphasize, and we want to emphasize social aspect of eating, so introducing spices, condiments, other than salt and sugar. You will also see that as we age, our taste buds will also start to, what's the word I'm looking for? Just not deteriorate, but only focus on two main things, and that's your sweet and your salty. I swear to you, every time I'm visiting my parents back home and go downstairs to visit my grandmother, she's got some sort of sweet chocolate, sweet cookie, sweet something. She's also an avid baker, which also helps that. But also some sort of salty, like cracker or chip as well. Then we have cognitive changes. So we have specific mental functions. So mild changes in specific mental functions can occur starting in late middle age. However, severe intellectual decline is typically unusual. This may look like a decreased attention to tasks, so their mind wandering is not shown, um, as well as a decrease in fluid intelligence offsets increase in crystallized intelligence. So remember, fluid intelligence is that processing new information, and that's what peaks in young adulthood, versus crystallized intelligence is using that knowledge gained over time as well as utilizing experience and judgment to decide how to respond to the situation. So at an older adulthood, you have a decrease in fluid and an increase in crystallized. Then you have executive functioning decline in those over 70. So the idea of abstract thinking, inductive or inducive and deductive reasoning, cognitive flexibility to devise alternative solutions to a problem decrease. More memory functions. So you have age-associated memory impairment, AAMI, which is memory impairment with everyday activities. So it's a very modest loss of memory in healthy adults over 50. So it's a pretty natural losing of a memory or memories. Then you have benign cessant or senescent forgetfulness, so BSF, which is a brief transitionary or transitory episode of cognitive decline. It's not necessarily related to aging. So healthy individuals can have briefly transitory episodes of cognitive decline, attributed to more of an attentiveness and a distraction rather than the aging process itself. So kind of like a, hey, I didn't catch that, or a, hey, I reminded you to do this, this, and this. Maybe I wasn't fully focusing on what you were saying, so I totally spaced and forgot that. This is why I tell you guys to email me when you have a conversation with me about setting up a meeting. I always need those extra cues. Memory loss can also be attributed to depression. Depression is often misdiagnosed as dementia in this case. So don't automatically assume dementia when memory loss is present. Then we have dementia itself, which is a deterioration of the intellectual faculties such as memory, concentration, and judgment, resulting from an organic disease or disorder of the brain. It's sometimes accompanied by an emotional disturbance and personality changes as well. So be on the lookout for that. Then you have your psychosocial changes. So depression, not uncommon. So think about this age. So this is going to affect about 5 to 10% of adults over the age of 65. A lot of this is typically misdiagnosed. So symptoms including loss of interest in things that were once interesting, including sex, loss of appetite with weight change, loss of emotional expression, persistent sad, anxious, etc. Um, think about this time period, you're dealing with a lot of loss. It's probably predominantly your friends that you grew up with, maybe some older people that you knew or family, friends, etc. You have that decline in physical function on top of that. Your leisure is impaired sometimes, and sometimes that support system is also lost. So it's easy to misdiagnose. The symptoms may seem similar to other illnesses. And then you have double risk of cardiac disease and increased risk of death from illness with that depression side effect. Your number of stressors tend to diminish around this age. So less stress, but maybe more difficult to recover from a stressor as we age. You have your mature defense Mature defenses to stress. So these are strategies to maximize gratification, allow more conscious awareness of feelings, ideas, and consequences. So the idea of altruism, maybe you deal with it through suppression, or my favorite thing is dealing with it with humor. Then you have self-care and ADLs. So they can retain independence well into late adulthood, possibly with use of adaptations. So think of environmental adaptations as well as task-related adaptations. Urge incontinence can also increase in both men and women. That's kind of like that feeling that you need to go to the bathroom, but you maybe don't necessarily need to go to the bathroom. This is the largest user of prescription medication. So medication management's huge. We have medication toxicity as well as medication reconciliation. So medication reconciliation is ensuring it can mix safely. You don't duplicate or you don't miss medications. So if you're on a whole host of medications, your pharmacologist within your SNF or wherever you're at will look into like, okay, if you take this drug, it's going to affect this one and this one and this one. You'd want to make sure that they interact well with one another. Then we have driving. So occupational transition, it's a major change in occupational repertoire of a person. So it's one or several occupations that may change, disappear, or be replaced with others. You see this in work demands as other occupations take greater importance in this age. Think of changes in your vision, your reaction times, your mobility, as well as the coordination will all affect your ability to drive. So this can also increase your risk of death, poor judgment, drifting, so whether that be falling asleep, not being able to stay in the lane, etc. Decreased ability to change behavior or response times as well. And then they have this program called CarFit, which is sponsored by AARP, AAA, as well as AOTA to determine one's fitness to drive and if their vehicle fits their needs. So we did this in school where we lined up at a SNF, or a SNF, not a SNF, like a day program for older adults, had them pull their car in, and we would just be able to see and adjust their seats if they need to, adjust their mirrors, etc., so that the car actually fit them for their purposes. Then we have housing. So the idea of aging in place. Most seniors want to stay in their homes as long as humanly possible. Uh, so my grandmother lived at her house in North Carolina. Like, granted, my parents have been moved away for the past like I would say 10 years. Lived alone pretty much until she was 84, 85. And really the push to move her back to Georgia with my parents was more so for my parents than for her. Just to have that comforting feeling of like I know exactly where she's at, and I know that if she needs anything, I'm like right there and available. Versus a 5 hour drive from Atlanta to Charlotte. So the idea of universal design is huge. So thinking about aging in place and like what kind of house that you buy and stuff like that, or maybe you buy the next house later in life. Think of those ranch style homes, the 1 story level where the master bedroom's on the first floor, etc. Like thinking of it that way. They often may move in with children and be taken care of. So an ADU, which is an accessory dwelling unit, sometimes referred to as a mother-in-law suite. So like I mentioned earlier in this PowerPoint, my parents were able to afford my grandmother to live with them under the condition my grandmother in place so that she have her own spot in the house. So my parents' house had an unfinished basement, and they were able to put in basically an ADU. It's like a 2 bedroom, 1 bath. She's got her own garage. She's got quite the setup. And then we have different types of communities if a senior still wants to live independently. We have long-term care is not as common as most people think as well. So the idea of putting them in long-term care is not an unpopular one by any means. Then we have relationships. 80% of older adults are parents of living children. Positive relationships reduce psychological impact of stressors per research. Relationships with partners are still important, as well as being able to deal with widowhood. So being able to deal with the death of a loved one. Then you have grandparenting as well. Those who are primary caretakers of grandchildren report more stress, but studies also show that watching grandchildren once per week, no more or less, is good for cognitive health of the grandparents. So it's both helpful and hurtful. Then we have work and leisure. So retirement age is in fact increasing. So our workforce is aging. So many people do not fully retire anymore. So you have bridge employment, which is any paid work after retirement. I know I'd mentioned my grandfather in class as far as he retired from the sheet metal factory up in upstate New York by the age of 50, and then he instantly went to go work at a pro golf course and became the pro at the golf course and worked there till he was 85. Similarly, my grandmother retired with Ford at age 50. They got a part-time job at a toy store when my sister and I were born. So the idea of like retiring, quote unquote, but also having like a part-time job in addition to. There's a mixed view on leisure in the US, but leisure does have profound health benefits for an individual. Then we have death and dying terminology. So we have palliative care, which is relieving pain and suffering, and then we have hospice care, which is a focus on pain and symptom relief, not treatment or extension of life. Hospice care is a specialized form of palliative care. So in hospice, they're trying to facilitate a good death. You can be at home or a facility. It's typically dealing with terminally ill or less than 6 month life expectancy. You have also advanced directives, which are written instructions for end of life care before care is needed. So you have a healthcare proxy, which is a person designated to make decisions. Living will, which is a document stating what procedures they want versus don't want done if unable to express preferences. And then you'll also see a DNR, which is a do not resuscitate. So do not take any extraordinary measures to revive me if I go into cardiac arrest. My mom and dad have their plans ready. They had them about 3 years ago. My mom saw her difficulties that she dealt with her father, my grandfather, and didn't want myself or my family to deal with that. So they literally sat us down, showed us exactly what they wanted. They literally ordered the plots. I think 3 or 4 years ago. It was like during Christmas. It was very depressing. But they said, "Here you go. Here's all the information. You do not need any more information from us." So with death and dying, we also have our 5 stages of grief. So we have our first with denial, second with anger, third is bargaining, fourth is depression, and fifth is acceptance. Keep in mind, grief is a common experience, but may be different for everyone. So the 5 stages of grief, you may go through them, but you may not necessarily go through them in exact order. There's often an increased focus on religion and family when we're dealing with death and dying. Mortality is dealt with differently in different cultures, so bearing that in mind when you're dealing with patients in this time frame. So just be cognizant of everyone's cultures, everyone's beliefs. Not everyone's going to believe what you believe in, and not everyone's going to want to do exactly what you would want done. So maybe begin accepting death by giving things away, planning a funeral, a plot, etc. And dealing with death can vary based on religion. So we have OT and death and dying. So it's underutilized in hospice care. It's very unfortunate. Medicare Part A, Medicaid, and private insurance will reimburse for modifying environment to continue their daily routines, prevent injuries to caregivers, and receive maximum functional performance to facilitate engagement and valued occupations. So focus on quality of life, not necessarily independence. Biggest focus is educating the family and to decrease the pain of the individual. That can look like range of motion, positioning, tone reduction, etc. Then we have evaluation, so we can do an occupational profile is especially important in this situation. We can find new ways to keep or adapt roles that they currently have. We can talk through energy conservation techniques. We can give caregiver training, as well as how to maintain social and leisure participation overall. And that is the end of our late adulthood presentation.